Hello and welcome to the Antibiotics Intern BootCamp lecture. We're going to be covering antibiotics by systems. Now this is not an exhaustive list, but it is something that you can kind of put a bookmark into your mind about what you need to be prescribing for what. In addition to that, I would also advise that if you could get an application like EMRA, Antibiotics, EMRA, it's $4.99 a year. It does develop antibiotics by systems, and it's very helpful for urgent care and clinic-like situations aside from its general use in the emergency department. So let's talk about stewardship for a minute. It's very important that, we've had this conversation over and over again that patients, I have a sniffle, I have a congestion, cough, I need an antibiotic. So realistically, you need to be able to prescribe antibiotics when they're really needed because of resistance, and that you're not giving them too much. For example, we've had recent changes in our gonorrhea chlamydia protocol. We've switched over from azithromycin to doxycycline, and we've also increased the dose for our Recephin doses as well, and that's because of resistance. So we also want to make sure we use the shortest duration of antibiotics. If you give a person 14 days of antibiotics for urinary tract infection when they only need 5, then who's to say that that patient isn't developing harm or resistance for other bacteria or genetically causing yeast infections and whatnot. So making sure that if you are going to treat something empirically, that if you do get a culture that you readjust your empiric treatment based on the culture results, and then making sure that your antibiogram is appropriate. So for example, what may work in one region of the country is not going to work in ours. A case in point example is that if you have someone who's using a common antibiotic like Bactrim or trimethoprim sulfa, then you're going to actually have a problem because most of our E. coli is a little resistant to it, and so therefore using an alternative antibiotic for the antibiogram is more important. Making sure that your staff is educated on if a patient comes in and says, I need an antibiotic, and they say, oh yeah, we'll get you an antibiotic, no problem. That probably isn't the best response. So making it clear once you get out into the private sector, if you do have staff that are triaging your patients into the clinic, that you're setting the goals of care from the very beginning. An interdisciplinary approach is something that we do prize ourselves on in the academic world. We do have a pharmacist that does digital medicine, and we do have pharmacy clinic as well. So if you have a patient that does require an antibiotic, having a healthy conversation with your pharmacist in order to verify your antibiogram and whatnot, and verify if this is the best treatment that the patient needs, is a very important thing. There's a case in point about this is if you have someone who's on sepsis, it used to be a Vanc and Zosyn approach on everything. Well, Vanc should only be used for MRSA, whereas Zosyn's more of our big gun for broad spectrum antibiotics. So there are other ways of approaching other than just blanket empiric therapy. And then making sure that you do a little education, preventing infections and controlling for infections, washing your hands, telling patients to wash their hands and whatnot. And it all goes down to antibiotic stewardship. You are the ones that are going to be responsible for the future, and the future is either going to be bright or dim according to what antibiotic resistance we have. So this was a card that we had generated at one time showing the gram-positives, negatives, anaerobins, and the atypicals. You'll notice that our fluoroquinolones will cover our atypicals, but then when you go into the meat and potatoes of things, for example, our third generation cephalosporins like Recephin or ceftriaxone will cover into the pseudomonal range, but then when you start talking about Unicin and Ancef and whatnot, those will only cover the gram-positives and your gram-negatives. Now, there is a graph that I remember seeing whenever we were going pharmacy, is that your first generation through your fourth generation for gram coverage, you start going for your first generation to fourth, and then you kind of level out, and this is for your gram-positive coverage, and then up here, as you go towards your third and fourth generation, you kind of have your nidus right here where you have your gram-negative coverage. So as your generations go up, you do get more cross coverage, which is great for our broad spectrum and evaluation. But then again, the fourth generations are more expensive. So speaking specifically about our penicillins, amoxicillin, which is one of our old workhorses, does cover gram-positive and gram-negative, but we have a big resistance profile here. ampicillin, sulbactam, or augmentin is going to be our really good one for our ENT infections, and you'll notice it does not have pseudomonal coverage right here. Zosyn covers everything. That's the reason why it's our workhorse in sepsis and broad spectrum coverage. We talked about our cephalosporins. Imipenem, which is very expensive and hard to get, does cover everything. Astrientam will cover gram-negatives and Pseudomonas. Our ciprofloxacin will cover our gram-negative Pseudomonas, and then we have a gap for anaerobes, but it does pick up back in atypicals, which is good for our Moxarella catarrhalis and our walking pneumonia. Moxifloxacin will cover some gram-positives, a little bit gram-negatives, and then it'll cover atypicals and anaerobes. Vanc is really for your MRSA, and you notice that Vanc is in the MRSA column here, and it will cover gram-positives, but you have to worry about renal problems with vancomycin, and they have to have Vanc troughs. Clindamycin is a good one that we can do for MRSA as well. Vancomycin, clindamycin, and linezolid are our ones, but remember with clindamycin you have to worry about our C. diff, and that could be a problem, especially with as much as clindamycin that we gave before. Clinda has no gram-negative or pseudomonal coverage, and it does cover anaerobes. Now, Flagyl metronidazole is really good for anaerobes, and this is what we use also for trichomonas and bacterial vaginosis. It's a one-time 2-gram dose, and even then, if someone can't tolerate it, because metronidazole does cause nausea and vomiting, and it does have a disulfiram reaction, you have to be careful with patients who you don't really trust that they're not going to have alcohol that day or within the first 24 hours after administration of that medication. So knowing what medications are important, and so there's two ways of learning antibiotics. There's antibiotic to system, and then there's system to antibiotic. And so, obviously in medical school, it's a daunting task to try and understand everything that's going on, and so therefore when you make these decisions, you need to either think about both, or when you start really getting onto the whole spectrum of understanding of what antibiotics go where, it becomes second nature, and you start thinking about, oh yeah, I need to give clindamycin, or oh yeah, I need to give augmentin. So let's talk about the content here. We're going to go by system, and we'll start by bone and joint. So first of all, septic joint, and so this would be a red hot erythematous joint. It's painful with decreased range of motion. You see the picture right here. It's obviously, this is not a well. This could be bursitis. This could be sepsis, or excuse me, septic joint. This can be an injured joint. It could be trauma. So you really need to think about the common organisms: Staph aureus, Streptococcus, Pseudomonas, and Enterococcus, with Staph and Strep being the most common. Now, if there's a concern, if it's a bad enough joint, then you're obviously going to get vancomycin for your MRSA coverage, and then ceftriaxone or Rocephin, which is our third-generation cephalosporin. Now, if you do have concerns for Pseudomonas or diabetics, then you're going to replace Rocephin with Cipro or cefepime. The duration is 1 to 2 weeks, and confirmations with joint aspirate. Now remember, these are IV. Cipro can be given oral, but I don't know specifically about the cross ability for ciprofloxacin to be able to convert to a PO for this, especially if it's serious enough. If you're giving vancomycin and another IV, they're going to need a PI, CC, or PICC line in order to receive this medication outpatient. So how long does it take to get a PICC line in place? Well, first of all, they may just do a long IV, which instead of the 1.5 inches, it might be 2 inches, and then you can send them home with that IV in place, and then you get the medication outpatient services, the compounding pharmacies, to deliver the medication, and then the patient can be taught and deliver that medication to themselves, which is a good thing, because in the back in the day they used to keep these patients for the full 1 to 2 weeks. But in the system that we have currently, if this is something that they can do at home, they can be taught, they're capable and reliable, then you can do this at home. Now, if you have gonococcal septic joint, then it's Rocephin IV, and it's going to be, again, 2 weeks. You're going to confirm that with joint aspirate, and then you're also going to need to check all of the areas, including the blood, for gonorrhea. You also will prophylactically treat chlamydia as well, and remember we talked about azithromycin used to be the way, but now it's doxycycline. So we just talked about our septic joint here. Now, septic bursitis, on the other hand, it does look staph and strep. You can use Keflex PO, amoxicillin PO, or cefuroxime PO, and you also need to add a Bactrim or TMP-SMX and doxycycline, or excuse me, or again, it's for 7 to 14 days, but if you have severe infections, again, IV antibiotics and hospitalization. Osteo, ooh, that looks like a bad bone right there. So Staph aureus, coag-negative staph, and anaerobic gram-negative bacilli, you're going to use Vanc for MRSA coverage, and Rocephin, again, if you're concerned for Pseudomonas, you change the Rocephin to Cipro. This is a long time, 6 weeks, and you have to confirm with MRI or biopsy. Now, remember, if you're putting someone on a long-term medication at home, especially for 6 weeks, they will qualify for a PICC line, and that's something that they will need to have ordered, inserted, trained on, and then have home health to evaluate and assist them at home. So let's talk about cardiovascular problems. Endocarditis, IV drugs is a big one we learned about. The tricuspid valve, Staph aureus, coag-negative, beta hemostrep, aerobic gram-negative bacilli, and Pseudomonas, vancomycin, 30 to 60 days. So again, PICC line for these people. If you have native endocarditis without IV drugs, again, Staph aureus, and essentially the same ones, same treatment, 30 to 60 days. So remember that if you hear a murmur and they're doing well, they're acute heart failure or whatnot, then you're going to have to be concerned for staph, and they're going to need to be vancomycin. Now, if they can't handle vancomycin, linezolid, but the price only goes up from there. So looking at our prosthetic valves, this is again going to be staph and the same medications, but now you have a difference in timelines here. It's less than 1 year or greater than 1 year post-op. And if you look right here, I put in the Janeway lesions, Osler nodes, splinter hemorrhages. Remember, Osler is painful if you think O for ow, and then Janeway is going to be on your palms and soles. I didn't really hear about the conjunctival hemorrhages, but that's kind of a secondary, not a major finding. So 1 year, less than 1 year post-op, it's Vanc, Rocephin, and Gent. If it's greater than 1 year, it's back to Vanc and Rocephin again. So you are going to add the gentamicin on there for less than 1 year. Now the big one here that we're talking about is meningitis. So meningitis is different from age group, remember? So if you have someone that's, a very young patient, it could be H-flu. If they are a sexually active young adult, it's probably Neisseria meningitidis. If they're an older adult, it's going to be strep pneumo. So Vanc and Rocephin, with concerns for HSV coverage, especially with HIV patients. Remember, your temporal lobe is affected with the HSV there. You're going to start antibiotics and then do the spinal tap, and you're going to keep these people in hospital, and you're going to continue to treat them for 14 to 20 days. Meningitis is a killer, and so therefore we must take this very seriously and initiate antibiotics very quickly. Spinal abscesses. So you see here's our MRI. You can see this huge abscess along the thoracic wall, and then over here on the lumbar spine you see an abscess along the sacral lumbar area, and then you have some bone destruction, which might have some vertebral osteomyelitis. So strep and staph, as well as some anaerobes, they say to do the spinal abscess of Vanc, Rocephin, and Flagyl. This is kind of a plus or minus right here, but the MRI is the definitive test of choice, and you're going to consider fungal for immunocompromised. So this is a bad day if you have a spinal abscess. If you have someone coming in that's had a history of IV drugs and now they're having back pain, and you have point tenderness on the midline, then that's usually a sure sign that you need to initiate further, more invasive diagnostic testing like an MRI. And I say invasive, I mean financially invasive. And so therefore, you can rule in and rule out this life-altering and problematic injury here. So let's talk about ENT. So we get a lot of these. We get a lot of ENT complaints, and you need to evaluate for abscess. You got to open the mouth and run your finger along the gum, see if there's any type of abscess formation and whatnot. The mouth is very dirty. It's usually polymicrobial. What do you do to treat a dental abscess? It's usually Augmentin, Clinda, or Unison IV. We usually send them out on Augmentin PO for 7 to 10 days with a close follow-up to the OMFS clinic, which is our version of dentistry. If they do have a dentist, they need to go in rather quickly in order to have this evaluated, lanced, and treated. Now, if it's so bad that you have some gingival hypertrophy and it's a really bad abscess tracking down, then you need to get them into the emergency department because you're going to need to get oral maxillofacial surgery involved. They're probably going to need to lance it and cut it open. Otitis externa is usually Pseudomonas staph or Peptostrep or a little bit of Bacteroides. If they haven't had antibiotics in a month, it's amoxicillin. If they have, then it's Augmentin or one of these medications. You can do a one-time dose of Rocephin if you're concerned that they're not going to be compliant. So the problem here is that this is the distinction that you need to make, especially for your pediatric patients, is that those patients that come in and they haven't had, they've had recurrent ear infections, you send them to otolaryngology to get, or excuse me, ENT to get them evaluated for a tympanostomy tube. But in addition to that, you also need to evaluate what medication you need to give and how frequently they're getting that medication. Amoxicillin is a lower strength than Augmentin. Augmentin has that blocker in it already, and so therefore using amoxicillin to eradicate at first, if it's unsuccessful, then you switch over to Augmentin because it does have that additional ability. Now cefuroxime, cefdinir, cefuroximine are also very good options. Augmentin's cheaper than these, and it's more readily available, and you're going to treat for 7 to 10 days if they're refractory and 5 to 7 days if it's just a preliminary issue. Moving in more internal into the ear, otitis media, you have strep pneumo, H flu, Moxarella catarrhalis, and then aureus and some viruses and whatnot. So what do you do to treat this? You can use a triple antibiotic drop for the ear. It's ophthalmolic solution, ofloxacin, Cipro and steroid, Cipro and steroid, or Cipro PO. So really, you see here we have 4 drops and 1 oral. So you want to start with the drops. You want to continue giving them the drops for at least 5 to 7 days. If they're refractory to the drops or they've had another, they're not doing well, then you switch over to systemic therapy with the ciprofloxacin PO. Let's talk about sinusitis. Remember, you have your ethmoid, maxillary, you have your frontal sinuses. People are going to report that they have a lot of pressure, pain, usually viral, but you could have a secondary superinfection. It usually lasts less than a month, and you're going to possibly have a headache, fever, nasal discharge, coughing. And so what do you do with this? Going along with our trend, you can use Augmentin or doxycycline for 7 days for adults, 14 days for pediatrics, but most are viral and don't require treatment. So it's usually best to just do a wait and see approach, where if they don't get better in 10 days with antibiotics, then you'll start to think about, oh, well, maybe I need to give them antibiotics instead. In addition to that, providing them an analgesic like ibuprofen, Tylenol, antipyretic, ibuprofen, Tylenol, nasal solution, 0.7 or 0.9% nasal spray. Intranasal corticosteroid / saline is also good, making sure that they are using that neti pot, clearing out their sinuses, blowing out their sinuses, in order to eradicate some of that pressure that they feel, as you can see right here in the maxillary sinus. So thrush is mild if it's only limited to the mouth, meaning that the tongue and the oral pharynx. You can use the clometrazole torches or nystatin swish and spit, and the nystatin swish and spit is very effective at it. Moderate, on the other hand, is going to require fluconazole. How do you differentiate moderate and severe? Dysphagia, difficulty swallowing food or fluids, and so therefore you're going to need to moderate your treatment according to their symptomatology. You'll see here the duration is 7 to 14 days, and making sure that if they do have dentures, that you're treating those dentures well, or else you're just essentially reinfecting the patient again and again and again. And trying to figure out, why do they have thrush? So if you have a normal, healthy, everything's fine, that come in with thrush, we need to figure out, do they have asthma? Are they using some type of inhaled corticosteroid? Or they have HIV? Do they have some type of cancer? And remember, the difference between leukoplakia and thrush is that with thrush you can scrape it off. With leukoplakia you can't. Leukoplakia would be an indicator that you might have cancer. So being able to differentiate between the two. Going into tonsillitis here, virus, group A strep, Neisseria, and diphtheria. So diphtheria we kind of get rid of with Tdap, but there are cases on the rise now with people starting to forego their vaccines due to vaccine hesitancy. And remember, you can have gonorrhea of the mouth, and most of the time it's just virus, and like EBV. EBV is a good one. It could also be strep, which we use the modified Centaur criteria here. So what do we use for this? Amoxicillin, cephalexin, or azithromycin. You can also use Augmentin as well. It says you can use penicillin. I've never used penicillin for this, but you can do it. And then 10 days. Now, the majority of viral, if you're thinking EBV, then you need to get a heteroviral antibody test. If you're thinking EBV, then you also need to give them the precautionary instructions not to be involved in any type of contact sports. And remember, EBV is the kissing disease / mononucleosis. You need to tell them to not share bottles of water and all that other stuff, and that they should not be doing contact sports for at least 30 to 60 days. If you do give them an antibiotic and they start to have the really bad rash, then you know that you probably have misdiagnosed this as a non-EBV. It should have been EBV. And then you just kind of, supportively treat that patient. Now let's talk about the modified central criteria here real quick. If they have a fever, it's +1. If they have tonsillar exudate, which right here we can see, that's a +1. Absent cough, they have cervical chain adenopathy. If they're younger than 14 or older than 44, we have a difference here. So if you're 15 to 44, there's none. If you're less than 14, then it is +1. Now, there has been some contention about this because you can get strep less than 3, even though the literature says you cannot. There are many anecdotal instances, and we've spoken about this at length, is that you can get strep at 1, 2, and 3. So it is not impossible to have strep at 1, 2, or 3. Now, if you're older than 44, strep is less likely, and so you get a -1. Now, what do you do with this score? If you get above a 1, meaning that you're 2 and above, you're going to start testing, and at 3, you empirically treat. So, understanding that the AAFP says that you test at 2, you treat at 3 and above. So, if they have a fever, tonsillar exudate, if they're not coughing and they have cervical chain, you're going to treat. If they just have fever and tonsillar exudate, you're going to just say supportive care and move on. So let's move on to the eye. All right, so here we have in the picture some conjunctival injection, and this is what we refer to as conjunctivitis. This is mainly caused by viruses, but it can be caused by a slew of other another bacteria, and some of these are more prominent in birth, like H. flu, gonorrhea, chlamydia, Pseudomonas for our contact wearers, and then we have staph and strep, as always, for our skin infections. So if you're not concerned for gonorrhea or chlamydia, you can use the polymyxin B Bactrim drops, bacitracin drops, erythromycin drops. Now, the erythromycin is more of a topical jelly. It's really good to stay on and provide you that relief. They also make erythromycin with a little bit of lidocaine in there, so it provides that patient with more of a relief as well. You can use a levofloxacin, moxifloxacin, gadafloxacin, and sulfositamide as well. So what do you choose? It's up to you, but really you also have to remember, how is this administered? Is it really just a liquid drop, or is it going to be a paste? As you recall with our newborns, when you put erythromycin, you just gunk it on their face. And so people may not like to have gunk on their face whenever they're at work, because they still can go back to work. So maybe a drop will be more better for those patients. Now, if they're not going back to work, it's the weekend, they'll probably get better in 2 or 3 days. Then you can just use the topical gel. Now, if it is gonorrhea or chlamydia, you're going to give Rocephin. Now, it says erythromycin PO. We've gone away with that. Now we go straight to Doxy as well. Most are viral. Contact wearers need pseudomonal coverage. And so don't forget, if they have a contact, take it out. No more contacts for at least 2 weeks. Throw those old contacts away and getting your pseudomonal coverage. So here we have a beautiful picture of fluorescent dye exam. You see a corneal abrasion right here. This is a opening for staph and strep. If they're not wearing contact lens, you can use the erythromycin gel, the sulfositamide, Cipro, or oflafloxacin, or even then, maybe not even anything. If it's not that bad, just have them, wash their eyes out and they'll be fine. Contact lens, if you're going to do Cipro, Offlo, gentamicin, Tobra. Tobra's expensive, Genta's expensive, but Cipro and ofloxacin aren't that expensive. But still, we're talking about $30 or $40 a bottle sometimes, depending on the market. So how long do you do this for? 3 to 5 days. Stop wearing your contacts. If you do have a corneal abrasion with contacts, then stop wearing them and then go see your eye doctor within 24 hours with the drops. So contact lens is really kind of a big picture problem here, is that, obviously the friction associated with using that plastic lens can cause you to have a disruption in the membranous aspect of the eye. So if they do have contact lenses and they do have a corneal abrasion, then that means that we need to elevate this to their specialist. Let's talk about gastro problems. Our favorite one is appendicitis. That usually starts the umbilicus and moves down into the right lower quadrant, and you are going to have your somatic pain located at McBurney's point, which is 1/3 the distance from the right lower quadrant to the umbilicus. So what do you do for this? Flagyl for the anaerobes, Rocephin IV, or Levo. And so you can also use ertapenem, moxifloxacin as well, but it needs to be IV. It's going to be for 5 to 7 days, and complicated appendicitis, on the other hand, can happen with people who are immunocompromised, HIV, poor nutritional states, significant or multiple comorbidities like diverticulitis, diverticulosis, healthcare-associated infections from a surgical site wound, or even if you're just pregnant, you might have a special instance as well. Cholecystitis is going to be inflammation of the gallbladder itself. This is mainly caused by E. coli, but can be caused by Klebsiella, NR Bacteroides, Pseudomonas, Enterobacter, Enterococcus, and so on. And so mild to moderate, you're going to start Rocephin or cefazolin, and it's going to be for 5 to 7 days. Severe includes clinical instability if you have recent cephalosporin exposure and you're still having these issues if you're immunocompromised. If you're thinking about MRSA and the patient has had an MRSA infection before, then you're going to need to treat for MRSA, and Rocephin's not going to cut it. So these individuals that you're going to diagnose with cholecystitis based on labs or physical exam, they need to come into the hospital from the clinic. So C. diff, on the other hand, you can see here we have a normal stool and then we have a C. diff stool. This is very malodorous, and if they do have C. diff and it's they're having more than 3 bowel movements in a 24-hour period, it's verified in the hospital, then you're going to start vancomycin PO or fidaxomicin PO or Flagyl PO. Vancomycin is now the first choice. It's going to be 10 days, and you need to consult infectious disease if they have any reoccurrences. Diverticulitis is mainly from our anaerobic bacteria that survive in the gut, and as we can see here, these diverticulae that are outpouching from the lumen of the large intestine. You can use Augmentin PO, Flagyl Cipro, or Flagyl Levo, or you can use moxifloxacin. This is for mild issues, it's 7 to 10 days. On the other hand, people who have severe pain, if they have increased lactate levels, those are patients you're going to bring into the emergency department, and those are individuals also that may have other healthcare associated previous treatment, immunocompromised or valvular heart disease, or even just extensive vascularized problems or coronary vessel disease and peripheral vascular disease. Those individuals may be at a higher risk for mesenteric ischemia as well as perforation. So again, if you're thinking about MRSA, you need to treat appropriately, and these medications will not cover MRSA. Let's talk about pulmonary for a minute, COPD. If you have COPD exacerbation, you can use azithromycin, doxy, cefuroxime, levo, moxy, or Bactrim. But usually most of the time we use azithromycin, and we do that because azithromycin actually has a inflammation reduction ability in and of itself as well. And so therefore you're going to probably use a macrolide like azithromycin when you have a COPD exacerbation. Now, there are many evidence-based medicine journal articles out nowadays that say that we should be antibiotic stewards and not just immediately start them on azithromycin, and that is correct. So it's always good to evaluate the patient holistically and evaluate them. Do you think that they have a pneumonia? If they have a pneumonia, is azithromycin going to cover it? Remember, CAP versus healthcare-associated pneumonia, you need to make sure that you're treating for the appropriate thing. Now, acute exacerbations with shortness of breath and sputum, you can use ipratropium, which is going to be our anticholinergic, which is very important to reduce the amount of mucosal generation, and albuterol, which is going to be our beta-2 agonist that causes bronchodilation. Now you're going to consider Pseudomonas if you have bronchiectasis, multiple recent antibiotics, if they've had frequent hospitalizations, which now you're starting to think about hospital-acquired pneumonia, or chronic immunosuppression with PO steroids. So you have to, again, think about the patient in their history and physical exam and evaluate what's going to be the most appropriate for them. So bronchitis and pneumonia are very different. With bronchitis, suppurative care with rest and an antitussive with bronchodilators will do the trick. You're not going to give them antibiotics, although if they do have an acute COPD exacerbation that warrants enough, wherewithal, then you're going to possibly consider antibiotics. You're going to consider influenza if it's during the flu season, and if it's within 48 hours, you're going to give them Tamiflu. And you're going to consider the Moxarella pneumonia if they have persistent cough greater than 3 to 6 months. Now that would be walking pneumonia. You're going to treat those with doxycycline. So influenza, Tamiflu, oseltamivir, you can use perimivir or zanamivir as well. It's going to be for 5 days, and recommended that the patient who does require hospitalization that with severe progressive illness is not just left out into the wilderness. They're brought in, especially if they're hypoxic, not feeling well, unable to tolerate food or fluids and whatnot. You need to start the oseltamivir or the other two within 48 hours, and that you have 2 weeks for exposure for household, meaning that if the patient is at a household that's full of people, then you need to ask that patient, is anyone on immunosuppressant therapy, is anyone severely ill, and as always, thinking about COVID-19. COVID-19 being our star of the show for the past years in 2019 and 2020, and being able to parse apart, is this COVID-19 or is this influenza? So let's talk about CAP, or community-acquired pneumonia. So you're going to have an infection in the lung parenchyma. It's going to be out of the hospital, and it's been less than 18 hours or 8 hours, excuse me, after their last hospital admission. So it's not really the hospital that caused them to get sick. The most common cause is Streptococcus pneumoniae. You're going to have fever, cough, sputum, rigors, pleuritic chest pain, dyspnea, possibly tachycardia from the illness. They're going to have crackles on auscultation. They could have problems with egophony, whispered palectricry, and tactile fremitus. So making all of that known, these are excellent physical exam findings. Not many people still do the egophony and the palectricry and all that. So the patient may have a bad chest x-ray, which we've seen over on our chest x-ray lecture. And so what do you do to treat this? Well, doxy, zithro, or amoxicillin, low gun, probably resistant gun, and then this is our most effective gun now. Now, if you have a high risk for MRSA or Pseudomonas, it's going to be Augmentin and then one of our cephalosporins, or one of our cephalosporins plus azithromycin or doxy, and that's going to be for 7 to 10 days. Now, if they have severe comorbidities, diabetes, alcohol use, active cancer, immunosuppressed, then we probably need to consider bringing them in for severe disease consideration and IV antibiotics. Skin. Animal bites. Dogs with Pasteurella, dogs and cats with Pasteurella, cats more likely, and then capnocytophagia with Canomoris with our dogs. And then you obviously have strep and staph. You can use Augmentin for most of these wounds. If they come back and they're having some problems, you might want to consider changing the medications, making sure that you're thinking about, was the wound appropriately cleaned at the time with soap and water and a deep injection of saline in order to flush out anything. You're never going to close puncture wounds, okay? Ever, ever, ever. You have to let it be able to express its purulence. And you need to consider rabies and tetanus. If their tetanus is less than 3 years on a dirty wound, give it to them. If it's less than 5 years on don't give it to them. And if it's less than 5 years on a clean wound, then you don't have to give it to them either. So remember, dirty and clean, I would say that if you get, bit by a rabid animal, that's a dirty wound. So making sure that you're understanding the terminology and giving them their appropriate vaccine prophylaxis. So human bites, viridans, bacteroides, and echinelic herodians. This is the one we learned a lot about in medical school. Augmentin, PO, or IV Moxie, or Unison, or you can do Clinda, Flagyl with Doxy, Clinda or Flagyl plus Doxy or Bactrim. So most of the time, people would just give them Bactrim. We give them Augmentin now. It's a little bit more effective than just Bactrim. And Bactrim, has some side effects on the kidneys and whatnot. We want to prevent those type of iatrogenic issues. You're going to use that antibiotics for 7 to 10 days. And again, never closing puncture wounds. You're going to also consider a hepatitis panel HIV test. Remember, those are bodily fluid transmission. Although the risk is low, it's still present. So making sure that those fight bites and whatnot that people come in, you're evaluating that effectively and getting them appropriately treated and tested. Cellulitis is mainly going to be Streptococcus, although it does have a staph origin. You're going to use Keflex, cefuroxime, or ceftriaxone. If it does have an abscess, then you're going to use Bactrim, Clinda, or Doxy. I would prefer Doxy over this instead of Bactrim. Again, we're starting to shift. And if the abscess is present and you have induration, then you need to do an irrigation and drainage. Also, if you do have an environmental wound, say for example this patient has abscess and they've been out in salt water or whatever, you have to start thinking about viridans, and you need to have other managements. But viridans is covered by our doxycycline as well. So understanding the context of the wound, how long it's been there, what has been exposed to, and what have they done to it is important. Now for an IND, obviously you can do this in the clinic. You can just inject it with lidocaine. make a moderate sized incision. Make sure that you wash it thoroughly out. That is the most important part, washing it out, and then putting a little stitch, maybe with a drain, in order to drain out the rest of the residual fluid slash purulence. So, diabetic ulcers, staph, strep, enterococcus, most likely polymicrobial. What do you do for this? You're going to use them Keflex or Cefuroxime PO if they do have MRSA. And you can add Doxy and Bactrim with the cross coverage. That's usually for 7 to 14 days. If they do have deep ulcerization, then you need to be very concerned for polymicrobial wound, with staph being the most common organism causing them to have osteomyelitis. Acute phase will require them to be hospitalized for that. Folliculitis, we have barbi, we have on the body, and usually, you hear about hot tub folliculitis. Individuals shave their legs, and now they had a party that night, and now they're coming back, and there's just like this horrible pustular rash on their body. And so what can you do? It's all topical, topical, topical. Chlorhexidine has actually been shown to be effective. It's a non-antibiotic, but it is a cleansing agent. It will clean those areas, get rid of any bacteria that may still be residing in the pores. You could use clindamycin or erythromycin, and chlorhexidine you can get a lot more for about the same price. So, your preference. 7 to 14 days, all right, and that'll go away. Impetigo, we all heard this honey-crusted lesion. It does happen with people who have chronic skin lesions, like our methamphetamine users, our young children. Staph aureus, MSSA, and group A strep. If it's isolated, you can use mupirocin topical. If it's numerous, you're going to use Keflex, and you should probably use a mupirocin topical as well. Now, if you're concerned for MRSA, it's Bactrim, PO, or Doxy, or Clinda. The Clinda may be a little bit better than the Bactrim and Doxys in the intermediary. Do it for 3 to 5 days, and consider oral antibiotics, as we've seen right here, with multiple lesions or people who have multiple lesions in the same household. So tinea capitis is going to be usually caused by Microsporum or Trichophyton. If it's topical, you can use the ketoconazole shampoo, and that's going to be our selenium shampoo or Selsun Blue. And if it's systemic, then you're going to use itraconazole, greasephulvin, or terbinafine. But remember, with your terbinafine, you need to get them to have a CMP or hepatic labs in order to monitor their transaminases. The itraconazole and the greasephulvin also do have some type of kidney problems, so you have to be very careful about that. So making sure that you keep them on for at least 3 weeks. And with the severe disease considerations, you need to be very careful, because these medications will interact with some of their organs that may be not working well. So the ketoconazole shampoo and the Selsun Blue are great. Selsun Blue is on the counter, and they can get that over at any grocery store. Selenium shampoo also helps them with dandruff and whatnot, and so therefore it's a multi-purpose medication. So the tinea corporis or pedis is usually caused by the Trichophyton. It's going to be isolated to one area. You can use the clometrazole topical for 4 weeks or ketoconazole topical for 4 weeks. If it's severe, you're going to use fluconazole PO, itraconazole PO, greasephulvin, or terbinafine. Remember, using these medications will require you to get some labs as well. Antifungals are a little hardcore on the body. Tinea versicolor is usually caused by Malacia furfur or Pityrosporum. So you can use the topical ketoconazole, terbinafine, cycloprox, Selsun Blue, or zinc pyrethroin. Now, each one of these have different amounts of days, and so some of these are cheaper than others. Selsun Blue is cheap, ketoconazole is a little bit more expensive. And remembering what your patient's budget is and what's going to be covered. Now, if you have systemic Malacia furfur, you're going to use fluconazole or itraconazole, and those would be an oral agent over several weeks. So let's talk about post-exposure prophylaxis, or PEP. So for meningitis, you're going to use Rifampin, Cipro PO, or Rifampin PO. So all household contacts, child care contacts, or direct exposure to patients' oral secretions. Now this includes EMS, okay? So if you have a patient that comes in that has a confirmation of meningitis, then you need to let the EMS people know if they came by EMS, as well as the family. This is very important because they need to take a Cipro. Their Cipro is going to help them prevent them from getting meningitis. Now, what's the risk of them getting meningitis? It's very low, but still, we owe it to the first responders and the family members to be able to protect them and not make more patients. What about HIV and hepatitis? So let's talk about the percentages here. Infection risk after a needle stick with HIV is less than 0.3%. So what do? Well, we're going to put you on Truvada or Descovy, and we need to get you started within hours. After you get stuck, you have to have an immediate HIV test, and then you have to have one at 4 weeks, and then one at 8 weeks. And that way we were able to definitively say you do not have HIV. Hepatitis B is approximately 0% with post-exposure prophylaxis, or 6 to 30% without PEP. Now, if you have a vaccine, you're probably good. If you don't have a vaccine, you're probably going to need an immunoglobulin with a vaccine if you've never been done before. Hepatitis C, 1.8%, much higher, much higher. There are no recommendations for post-exposure prophylaxis, even though they started talking about DAT therapy, like we've talked about in the hepatitis lecture, just for a month or a couple weeks, but that has not been formally recognized by the CDC. So with HIV, PEP is given for a month. You're going to test the complete blood count, renal, hepatic functions after 2 weeks of treatment. So the cytarabine and the tenofovir are going to be Truvada. You can also use the Incentress or raltegravir. Now you'll notice here it says that you can give this twice daily. Now the preferred regimen, and this is coming from one of the infectious disease journals, is that you can do a double or a triple therapy. Truvada is the double therapy, and then they add this Incentress in here. It is sometimes inappropriate to add a third agent in, because with PEP therapy it's usually just Truvada or Descovy. So you want to make sure that when you are giving this, that they are taking it with food, and they can take it at nighttime as well before they go to bed, to avoid, just like we do with our statin drugs. So let's talk about the risk of transmission here, okay? So it's anywhere from 23 to 62%. That's a big deal. So if you do have an exposure, then you need to get treatment if you have not been vaccinated. So unvaccinated gets the immunoglobulin and the HB vaccine series. If they have been vaccinated but they didn't get all 3 doses, again, HBIG and revaccinate. If they have been vaccinated and they've already had like 6 doses, meaning that they were a non-responder, then you're going to get them immunoglobulin separated by a month. Now, if you don't know the antibody response, then if they do have adequate, it's no treatment. If they do not, then you give them the IG. Now, why is this important? Because if the source is surface antigen negative, then we're all good. If the source is surface antigen positive, then we need to get them under control. If the source is not tested or status is unknown, but they've been vaccinated, it's no treatment. So remember, it's either I've been vaccinated, I'm fine, I know my titers are fine, I don't get a treatment, but if I'm not vaccinated or I'm a non-responder, I probably will need to get my immunoglobulin. So rounding out hepatitis C, there is no effective prophylaxis. Immunoglobulin and antiviral agents are not recommended. You have to determine the source, and you need to make sure that you're doing repeat testing, because there is a chance that you will not be able to contract this. Now, if you do contract it, early treatment with a DAT is warranted, and you go to the hepatitis clinic or referral to hepatologist. DAT is roughly 6 weeks. It's covered by insurance, and then you're free for the rest of your life. So I just wanted to close out with Lyme disease. There are many parasitic infections, and this is not exhaustive, but Lyme disease is you correct the problem and you get rid of the tick. You make sure that if the tick was attached more than 36 hours, then you might need to treat, and then you look at the correct geographical location as well. You're going to treat with doxy, but you do not treat asymptomatic seropositive patients, and you're not going to give doxy to pregnant or nursing mothers because of the teeth and the baby issue. So you have to identify, make sure it was attached more than 36 hours, and make sure you're in the right location. Although the Ixodes tick versus a Lone Star tick, it's pretty much all treated by doxycycline, babiosis, Lyme disease, so on. So it's fortunate that doxy is our go-to for this. And that concludes the antibiotic lecture. I hope you learned some things. If you have any questions, we'll look forward to answering them. Thank you.